Hey, everybody, welcome to That Expert Show, where you help run the show. I'm Anna Canzano. Thanks for joining us today. Today, we're talking about breast cancer. It is October, it's Breast Cancer Awareness Month, so I figured this would be a great time to talk about this disease, which is now more common in women, really more common than women aside from skin cancer. And I was shocked to learn that just in the last decade, the number of diagnosed cases worldwide of breast cancer has gone up by 20%. So today we'll be talking about risk factors, we'll be talking about prevention, the latest information in diagnosis and treatment. And we have an amazing expert lined up today. She joins us live from the Cleveland Clinic. She's a breast diagnostic radiologist, Dr. Laura Dean. Thank you so much for being with That Expert Show.
Good morning. Thank you so much for having me.
I'm excited to talk with you because I think this is a topic that a lot of us have been impacted by. We've had either friends or relatives that have been diagnosed with breast cancer, and we've watched them go through the process. But I might be in the group of people that's been a little bit ambivalent about learning really the intricacies of breast cancer. I mean, I do the mammograms, I do what I'm supposed to do, but I'll be honest with you, I don't know a whole lot about breast cancer and the signs to look for and the prevention techniques. So maybe we can start talking with you about some simple lifestyle strategies that you can offer folks when it comes to warding off this disease.
Sure. Well, it's important to mention that unfortunately there's nothing that specifically can be done to prevent breast cancer from occurring. But there are some lifestyle modifications that may help to reduce a woman's risk of developing breast cancer. These include basic health changes, such as maintaining a healthy weight, being as physically active as you possibly can, eating a varied diet, so a wide variety of fruits and vegetables. We like to describe eating the rainbow, so lots of colorful fruits and vegetables every day. Limiting alcohol intake is becoming a little bit more important as we learn more about breast cancer, and then quitting smoking. So if you're a smoker, limiting smoking or quitting smoking altogether.
And you can do all of those things, like you can have those down to a T, but if you have a genetic history of breast cancer in your family, you are predisposed to get it at a much higher rate than others.
That's right. And we do know that the biggest risk factors in general, other than just being a woman and an aging woman, so we know that breast cancer is in general a disease that increases with aging. But the biggest risk factors overall are family history. So any families that have a strong prevalence of breast cancer, especially in a family member who's a mother, a sister, or a daughter, those are patients who are going to be at higher than average risk of breast cancer. And then, of course, the patients that have a genetic mutation, such as the BRCA1 or BRCA2, which are the most common ones that we hear about that really increase a patient's risk of breast cancer.
You know, when you talk about risk as far as things that people have done in terms of their lifestyle that predisposes them to coming down with breast cancer, there is the thought out there that, gosh, if you've done any kind of estrogen treatment in your lifetime, whether you were on the pill for contraception, or I think there's a lot of women who have done hormone treatment for fertility issues. Does that put you at a higher risk for getting breast cancer?
That's a really good question, and that's a question that we debate a lot, and there's actually a lot of controversy and a lot of debate about that throughout the medical literature. There is some evidence to suggest that previous hormone replacement therapy, for example, may increase a woman's risk of developing breast cancer. However, it's important to remember that there are multiple different formulations of those hormone replacements. They have varying degrees of estrogens related to progesterones. So that makes it very complicated to sort of tease that out. We do know that in some cases, those hormone replacements or hormone treatments, such as birth control pills, may actually be slightly preventive in terms of developing breast cancer. So similar to, in a way, a woman who has had a previous pregnancy or a woman who has had a breastfeeding history, those are important parts of a of a person's medical history that may actually decrease breast cancer. So it's very difficult to say exactly what those factors are and which hormone replacement medications may actually be accounting for an increased risk. It's very difficult to tease that out.
You brought up the idea of breastfeeding, and I heard from a lot of people on this topic, friends included, and a friend who has just finished her cancer treatment wanted to emphasize that she wanted women to know you can and should get a mammogram when you are breastfeeding. She had a referral, but says that she was turned away because she had checked that breastfeeding box. Consequently, between being pregnant and breastfeeding, she didn't have a mammogram for 8 years and wound up getting a diagnosis of breast cancer within the last couple of years.
So what I would say to that in terms of the issue of being pregnant and or breastfeeding, we know that pregnancy, just because of the physiologic changes in the breast that occur during pregnancy and then during breastfeeding after pregnancy, that is when the breast tissue is at its most dense. That is when the breast is the largest, it's the most well-developed. There are a lot of water and fluid changes inside the breast. So while we don't typically recommend a mammogram during pregnancy, also because of the very small amount of radiation that's involved for the fetus, and then during breastfeeding, we typically don't start with a mammogram or do routine mammography because of that dense breast tissue. That being said, if a woman who is pregnant or who is breastfeeding has a symptom, if they have an area of a lump, a mass, anything that they feel is out of the ordinary for their breast tissue, they still should come in certainly to see their provider and to have some sort of evaluation for that, even if it's just for reassurance that it may just be normal physiologic changes.
Yeah, that's hard because with breastfeeding, a lot of issues can come up. You can get duct blockages and you're kind of paranoid anyway because you're in nesting mode and everything can feel like it's a problem. But you're saying that it's okay to advocate for yourself and at least come in and have that conversation with your provider.
Absolutely, and that's what we're here for, even if it's just for reassurance that everything is normal.
You mentioned, if something feels out of the ordinary, and I think with breast cancer, it's like with a lot of ailments in your body, you might think that your first indicator is pain, like something's hurting, therefore something is wrong, but that is not often the case when it comes to breast cancer, right?
That is correct. So not to say that an area of pain should be ignored in the breast, but in general, the cancers that we see are not typically presenting because of pain. So typical things that we ask patients to watch out for, I briefly mentioned them a little bit in our last question, but any lump that's developing, mass, thickening, changes in the skin, also paying attention to the armpit area. So the lymph nodes in the axilla or the armpit area, anything out of the ordinary in those areas would warrant an evaluation. In terms of pain, we would want a woman to come in and get an evaluation for pain. Most of the time, we can reassure her that these areas of pain are not because of cancer. Doesn't necessarily mean that you have a cancer because you have pain. Pain in the breast is actually very common.
Right. And is there an area of the body where the breast cancer is more likely to develop as you look at cases over time? Is it that armpit area that generally gives people more problems?
So we know that the breast cancer starts inside the breast, and then just because of the drainage pattern of the breast tissue, if it is going to spread outside of the breast, the first place that it is most likely to go is to the lymph nodes in the axilla or the armpit area. So that is why we very closely evaluate the axillary lymph nodes anytime there is a question about the breast tissue or if a cancer is diagnosed inside the breast. That's the first place that we're going to check for spread.
Interesting. Okay. We have folks that are chiming in about this interview. This woman wanted to remain anonymous, but says, wow, I was just diagnosed and I'm waiting for the meeting to find out my plan of action. I am grateful for annual mammograms and cannot stress the importance of them more. My journey is just beginning. So I'm glad that we could help her with this topic. We had a couple of folks who wanted to know about genetic testing. Heather on Facebook says that she's adopted, so she has limited family history. Trudy on Facebook says her sister has metastatic breast cancer. Cancer runs rampant on her father's side of the family. In fact, of my generation of cousins, 80% have had or has cancer. I guess my odds aren't good. Do you recommend genetic testing, and what are the pros and cons to genetic testing?
So what I would say about the question of genetic testing is it may be most helpful initially to talk to your provider, who may be able to get you in touch with a genetic counselor who can really narrow in on your family history, specifically which family members have been affected, what types of cancer they had. The genetic counselor can really help you to talk through all of those questions, and then they can help to tease out the pros and cons of doing genetic testing. The pros being, of course, knowing if you were to be one of those carriers of, say, BRCA1 or BRCA2, knowing that information is helpful for you as the patient, but then also for any potential family members who may also be affected. On the negative consequences, that's a lot of information and it's a lot of weight to carry. And so that's another reason that it should really be done probably in conjunction with a healthcare provider of some sort, either a trusted family physician or an OBGYN or a genetics counselor who can really talk you through what do these results mean, what do I do with this information, and how does it impact my family.
Are genetic tests usually covered by insurance?
It depends. And as we know, every insurance carrier is so different. They're so varied in terms of what they will cover and which patients it may cover the test for. So it's certainly worth inquiring about. It may or may not be covered depending on your overall risk factors and family history.
Got it. Okay. Janice on Instagram wanted to know, how accurate are mammograms? Do you really need to get the 3D mammograms? Are they more effective?
So we know that mammography is really the gold standard for breast cancer screening. So we have decades of really good, solid scientific evidence showing us that mammograms save lives. And we really, most lives are saved when mammography is performed every year, beginning at the age of 40. We know that mammography is not perfect, as no screening test is perfect. What has really revolutionized mammogram screening within the last several years is something called breast tomosynthesis, or the so-called 3D mammogram, which you alluded to. What that means essentially is a woman's breast is still compressed in the same manner as a traditional two-dimensional mammogram. While the breast tissue is compressed, the machine essentially kind of scans across the breast tissue, almost sort of like a mini CAT scan for the breast. What that allows the radiologist to do is scroll through the woman's breast tissue, and it's really increased our visibility of cancers inside breast tissue, especially dense breast tissue. And another benefit of the 3D mammogram is that it also decreases false positives. So it decreases the chance that a woman may be called back for something that was just an abnormal flag.
And so the chances are that a mammogram is going to catch the first signs of breast cancer before any kind of self-check or lump could alert you?
That's exactly right. And that's why mammography is so important, and screening in general for breast cancer is so important, because the whole goal of screening is to find cancers at the very smallest possible size. And mammography allows us to do that. It allows us to find the cancer at least a year, sometimes years prior to when a woman would be able to feel that cancer. And that's what we really want. The smaller cancers in general are going to be easier to treat, less invasive surgeries and less invasive treatments.
Let's talk about that. If you can, just walk me through. So let's say I've had the mammography, something unusual came up in hopefully the 3D mammography, and then what happens from there? Do you go immediately to a biopsy, or what is the treatment plan?
So that's a good question. And what I want people to know is that it is not uncommon to get called back for additional diagnostic testing. So a callback from a screening mammogram is really fairly common. The majority of those women who get called back will have some additional testing, including possibly more mammogram imaging, potentially an ultrasound. A lot of those women will be cleared and they will be able to return to routine screening. So just the fact that you're called back does not necessarily mean that something is wrong. And in fact, most of those cases will still be okay. A small number of the patients who get called back may have a finding that will ultimately go on to a biopsy. And then a very small number of those will be found to have breast cancer. So a biopsy is not necessary. It's not a knee-jerk response to just being called back from a mammogram that's been flagged as abnormal. All that means is that there's something that's caught the eye of the radiologist that they just want to investigate further.
Interesting. This brings up a question that a woman posted on Facebook asking about advocating for herself. She says she's 39, discovered a lump 4 months ago, family history of breast cancer, mammogram and ultrasound in June, found 2 cysts, and gave her instructions to come back in 6 months. She was told not to worry, as not much can change in that time, and it is safe to wait. If they see noticeable changes in December, they will biopsy then. But she says she's scared to death. The lump has changed. There's pain associated with it now, and she's concerned. She says, she thinks cancer doesn't cause pain and everything's fine, but what if it's not? She's scared and she feels like just a number, but she's wondering if she should call and bug her doctor and check sooner. Is 6 months really safe?
So I always encourage my patients to be your own advocate. So even though you have the advice of the doctor who had evaluated your imaging, if you ever feel like something is not right, if you're not comfortable with the plan that has been proposed, especially if you feel like something is changing, I would say it's always appropriate to advocate for yourself. Give your doctor a call. Either they can help kind of talk you through what you're feeling, or they may be able to help to get you set up to come in earlier. It's never a bad idea to be your own advocate, especially if you feel like something is changing.
Can we talk about the treatment process? Because I think there is some positive news as well to share with folks that there are such advanced treatment options for nowadays that if you are diagnosed with breast cancer, this is not the death sentence that it may have seemed like it was several years ago.
Absolutely, and it is really exciting to see the way breast cancer treatment has changed over the last years and even decades. We're now able to, in many cases, because of screening and because of shows like this where we're really raising awareness for breast cancer, we're finding them much smaller, much earlier stage. And what that means is that oftentimes we can use less invasive treatments. A lot of women, depending on the profile of their particular cancer, may even be able to avoid chemotherapy. We're able to do surgeries that are not as invasive as what they might have had to do in decades past. And all of those have benefits for women who are now living long lives with a history of breast cancer.
So the spectrum of treatment options includes surgery, as you mentioned, chemotherapy, radiation is still on the table. And are there other types of treatments too that are coming on the horizon and showing to be effective?
Sure. So you mentioned surgery. Surgery is almost always involved for breast cancer in some form, whether that is just a localized excision or a lumpectomy or the more aggressive mastectomy, depending on a woman's breast, what type of cancer she has, and her wishes for her surgery. But we know now that there is a much more individualized approach to cancer treatment in general. So what we mean by that is that cancer care is not one size fits all. So we're learning more about genetic makeups of certain types of tumors. That may mean that they might have a better response to one type of chemotherapy compared to an older type of chemotherapy. Maybe it's a chemotherapy that doesn't have quite such a toxic profile. And so those are really things that people are investigating at length to see what can we do about these specific tumors. How can we target our therapy for these women to give them the best effect with possibly less invasive treatments?
A friend of mine, the one I mentioned, who has just gone through this whole process, was really pleased that she was able to keep her hair because of a process called cold capping. And I think that's, can you explain what cold capping is and how that helps you keep the hair on your head?
Sure. So what I know about it, and in general, when people hear, I need to have chemotherapy, one of the first thoughts is, oh my gosh, am I going to lose my hair? And so some people have really been looking into that. What can we do that may help women to keep the hair on their head while they're going through treatments? Something called cold capping was developed as a method to try and prevent hair loss. What I know about it is that the woman Essentially, there is a cap that has cold coils in it that goes over the woman's head while she's receiving chemotherapy infusions. I don't know a lot about the scientific, how successful it has been in general, but I know that it's being used at multiple different facilities and that people are having success with this. There are women who have actually gone through chemotherapy. It may not completely prevent hair loss, but it's minimizing it so that they don't have total hair loss, which is a really amazing development.
Well, and I don't want to ignore the fact that breast cancer also affects men as well. Is there a certain percentage of men that are diagnosed with breast cancer, and they're often not talked about in this conversation?
Yeah, we don't talk about men as often, but it is important to know that certainly much less common than we see in women. But there are about 1,200 cases a year of breast cancer diagnosed in men in the United States. And unfortunately for men, they tend to present with slightly larger tumors and possibly a slightly higher stage. And the main reason for that is men aren't routinely screened. So they don't come to medical attention until they actually feel a lump or see a change in their tissue that brings them to medical attention.
Interesting. And I would have to think that a lot of those men are being diagnosed with cancer also because of some kind of genetic history that's predisposing them.
Some of them may be found to have genetic predisposition, but not all of them.
Okay. There is a pretty specific question on Instagram from Janny the Granny. She wants me to let you know that she has BRCA1, BRCA2. She's HER2 positive. Maybe you can help explain what that is. And estrogen positive. She had genetic testing after she got news that she had breast cancer. She also mentions that the cancer marker they put into her to mark her cancer with titanium wound up giving her 4 infections, and she had to get that removed. I don't know anything about that.
So she mentioned her genetic predisposition being BRCA1 and BRCA2. It is more common to have either isolated BRCA1 or BRCA2, but rarely there are patients and groups of families that have both BRCA1 and BRCA2. Those patients are at very high increased risk of breast cancer. From the question that she described, it sounds like she already had a breast cancer, unfortunately. What she described as HER2 and estrogen positive, anytime breast cancer is diagnosed, the pathologist tests for 3 basic genetic traits on that particular tumor, and those are estrogen receptor, progesterone receptor, and then something called HER2. These markers and whether they are positive or negative gives us more information about that particular tumor in that patient. And then, as I briefly described earlier in our conversation about individualized therapy, it helps us to kind of target treatment for that particular tumor based on whether it may be estrogen positive, estrogen negative, or HER2 positive, and kind of those different combinations. So the fact that it is HER2 positive gives us information about a treatment, specifically something called Herceptin, that may be helpful in treating that patient's cancer.
Fascinating. I wanted to say hello to some of the folks that are watching on Facebook. Rhonda and Merrill, Bunny from Otis, thanks for tuning in. Gabe as well. Amy on Facebook wanted to know, what are some general symptoms? And you might have covered this, but I wanted to make sure that we just got her question in. Amy wanted to know, what are some of the general symptoms to look for that have nothing to do with physical changes in breast tissue?
So one thing that I think is important kind of on that, on the basis of that question, is just general breast self-awareness. So I want patients to know, in general, what does your normal breast tissue feel like? So what are your normal monthly cyclical changes? You hear a lot about breast self-exams. Should I be doing self-exams? How often should my doctor be doing a self-exam? Those questions are a little bit more difficult to answer, and breast self-exams can be really difficult because of those normal lumps and bumps in breast tissue. So I talk to my patients a lot about breast self-awareness and knowing kind of what's normal for your breast tissue. So we talked a little bit about changes, palpable changes like a lump, pain, redness in the skin, any kind of a change in the weight or the feeling of a breast that's asymmetric, meaning it doesn't feel the same as the other breast. These are all sort of physical things, maybe not a lump necessarily, but that should bring that patient to medical attention.
So other things that might be a little more nebulous, like fatigue or weight gain or loss or other kinds of things that you would associate with other types of ailments, don't necessarily apply to breast cancer?
Not necessarily, but certainly if a woman is feeling more tired than normal, weight changes, especially unsolicited weight loss, would be something to bring to medical attention, so the doctor can really run some tests and help to figure out what's going on. Is this just normal, or could there be something else going on? Not necessarily specific to breast cancer, but just general health for that patient.
And I wonder too, when it comes to breast cancer, are there particular demographics in the population that are more prone to being diagnosed with breast cancer than others? Is it more prevalent among white women versus women of Asian descent or Black women?
We know that breast cancer unfortunately occurs across all demographics and all populations. We have talked in this conversation about the BRCA1 and BRCA2 genetic mutations that confer really the highest risk of breast cancer. Those are most popular or prevalent in the Ashkenazi Jewish patient descent. And so that's certainly an important question that we want to know. Is there an Ashkenazi Jewish history in that family's profile? We know that African American women tend to have possibly more aggressive type breast cancers, and so we really want those women to have early screening and conversations with their doctor about the appropriate screening profile.
And what do your kind of hormonal cycles have to do with the onset of breast cancer? If you start menopause late versus early, does that have any impact on the prevalence of cancer?
It can, and this sort of plays into our discussion from earlier in the show about hormone replacement therapy, and it's kind of along the same lines. Your lifetime exposure to estrogen may play into your risk of breast cancer. So if you started your period at a very young age, that may mean that you've had a longer lifetime exposure to estrogen. Similarly, if you had later onset menopause, that may mean that you had a longer exposure to estrogen.
Interesting. Any last thoughts that you wanted to share with our viewers before we let you go?
Sure. So I think the most important thing that I want all women to know is that we talk a lot about high risk and genetic mutations and family history. But it's really important to know that most breast cancers that we diagnose are in patients who have no family history of breast cancer. 75% of breast cancers occur without a family history. So if we only focus on the high risk patients or those who have a known genetic mutation, we're really missing a large proportion of those breast cancers. So that's why screening is important, and screening for all women.
So you said 75% of all breast cancer is diagnosed in people who have no family history. Wow, that is a statistic that we will definitely get out there. Thank you so much for your time and for your insight and for sharing your knowledge with us, Dr. Dean.
Thank you for having me and for helping to raise awareness for breast cancer.
And thank you for joining us for this episode of That Expert Show. Wow, 75% of all cases of breast cancer are diagnosed in people who have no family history. We'll definitely get that information out there. We always summarize the information that we cover in the episode in a tip sheet, which we provide on our website, thatexpertshow.com. You can always connect with us on social media. I'm on Facebook at Anna Canzano and Twitter and Instagram at That Expert Show, where you can also watch the rebroadcasts of this episode. You can catch them as well on our YouTube channel, That Expert Show. And I know life is busy, so it's not always easy to watch videos. Sometimes it's just easier to listen to a podcast. We put this content back out to you on Apple iTunes, Google Play, Stitcher, Spotify, TuneIn, all those good places as well. Thanks for being part of the episode today. Thank you for suggesting all of the questions and for sharing your stories about breast cancer. I really appreciate your input. That's really what makes this show work. It's kind of a two-way conversation because I don't always have all the questions that you want answered, and I'm happy that we're able to line up the experts and get you the answers that you want directly through the show. It is called That Expert Show, where you help run the show.